Alrighty. It's been a hot minute. Let's jump into this. We have way too many studies to get through. Now, taking some advice that I got from some of you guys, we're going to treat this more as fast facts. So while I can take an hour just rambling on 5 studies, considering the amount that we have to get through, as well as how you guys prefer to learn these as more as snippets of information, I'm going to try and condense it and keep each individual study between 1 and 3 minutes, just giving you a faster fact version, unless there's absolutely a need for the exception. So let's just go right into this. Title: Efficacy of blood flow restriction training in chronic ankle conditions, a review. So with this, they really just wanted to see, does blood flow restriction, so putting on a, for lack of a better word, blood pressure cuff and squeezing it to the point where your blood slows down returning to the heart, does that improve ankle conditions when you slap them on versus if you don't? And what they found was the BFR, so blood flow restricted rehab, appeared to enhance the dynamic balance. So you actually, as your body shifts around, like you stand on one leg, and it improved perceived ankle stability in patients with chronic ankle conditions. It didn't really help joint ranges of motion. It didn't help a lot of the secondary things. But if somebody has chronic ankle instability, they're fresh off of an ankle sprain, but not to the point where they still have edema and swelling, and they can tolerate, because that's another big thing when it comes to blood flow restriction, is tolerance to the therapy. If they can tolerate the therapy, then it's a great intervention. If you can't tolerate the therapy, or we're not really going for the dynamic balance portion, we're able to take along whatever it is, you don't absolutely need this. It just stands to reason that, according to this study, if you can handle it, if you have it available, it's kind of a why not scenario. Next up, the effects of different types of mid-back manual therapy for shoulder dysfunction. This is what these ones I always find not only fascinating but really beneficial to patients, because again, some patients come to me because, oh, I don't want a chiropractor adjusting my neck. Fine, we don't have to. There's loads of ways to get benefit, and there's loads of different approaches in different areas of the body to get benefit in the area you're treating, but also indirectly in areas you're treating indirectly. Like, as the title says, we're doing something to the mid back that's helping the shoulder. Reason being, the shoulder is attached to the what? Basically mid back. Well, you've got the glenohumeral joint attached to the, you have the humerus attached to the glenohumeral joint, which is on the scapula, which is on the. We don't need to get into the actual anatomy of it with joints versus pseudo joints and all those things, but the arm bone is connected to the torso bone. So what does that mean when it comes to treatments and therapies? Well, it seems that we can actually get benefit of doing some soft tissue work to the actual mid-back region and get benefits into the shoulder. So they took a look at different subtypes of mobilization that I'll just kind of skip right now. They found that adjusting, so chiropractic adjusting, this HVLA, and I say chiropractic more just so that you guys understand what I'm talking about. In reality, there's tons of different professions that do it. But anyway, HVLA thrusts lack benefit to the shoulder for shoulder pain. So the shoulder joint is one that I will ramp up. I don't just start with adjusting. So if we're working on a shoulder together, I'm not just going in there and making or trying to make things pop. I usually will progress and do, what is the lowest effective dose? Is it here where we're just moving it around slightly? Nope, we need to go a little bit harder. We need to, hold it at a comfortable end range and back off and do it different types of, they're called mobilizations. So not where you're doing the quick, thrust maneuver and trying to make this big pop, but let's get a little motion in there and test the waters a bit, because this is already a very mobile area. It doesn't always need the really fast, big adjusting stuff. And that's what they found here, is adjusting it for pain doesn't seem to be doing a whole lot. However, you can adjust the mid-back and sometimes get benefits to the actual shoulder. You can include hands-on, tool-assisted, which includes cup or scrapey tools. IASTM, I should be a little bit more professional here. You can include some modalities, so radial shockwave, certain types of stem devices or e-stim devices. I would probably lean more towards like a muscle stimulator than just a TENS muscle relaxer. These things have shown to get upstream benefits to improving shoulder pain. All of these, though, had limited data when it came to adhesive capsulitis because that's a different beast on how and why the shoulder is locking up versus your run-of-the-mill aches, pains, and general tightness, okay? There's different things we can do for adhesive capsulitis, but we have to put it in its own separate category because it is entirely different. Let me just quick skim to make sure I didn't miss anything I wanted to talk about. Uh, Again, this one's all studies are going to say further high clinical randomized trials are warranted to confirm findings and compare and contrast against, which you're never not going to see something. Oh, about the adjusting, HVLA or that chiropractic adjusting thrust techniques did not demonstrate effects in individuals specifically with subacromial pain syndrome and adhesive capsulitis. So they wanted to just re-emphasize that kind of what I said. You can adjust and get some pain benefits for certain shoulder conditions, but if they're talking subacromial pain syndrome and adhesive capsulitis, not that great, which is also why we have a ton of different tools. Next up, machine learning prediction for identifying individuals requiring rotator cuff repair. Shoulder muscle strength and questionnaires were assessed. So what did they wanted to do? They wanted to see if the shoulder functional questionnaires and objective strength tests were sensitive enough to detect if somebody would need an actual shoulder intervention. And I believe this one was for arthroscopic repair. So once they had everybody answer these questionnaires, and again, it was a small sample size, so take this with a big grain of salt. They found that you had a lower risk or lower need of having an arthroscopic rotator cuff repair if you had better abductor, so being able to kind of lean away from here, so being able to raise my shoulder up and out like this. So if that was stronger, odds were I didn't need to go into surgery. If I was younger and I was overall more subjectively, so my opinion about myself, more functional, I wouldn't need the actual surgery. If I couldn't really raise my shoulder, if I was older and I just didn't really have a good mindset going into it, you probably were going to get the rotator cuff repair. So something we can add into preoperative screening, essentially. Next study. Effectiveness of exercise therapy versus passive conservative treatments for rotator cuff related shoulder pain. This one, if you just read the title, you'll think that just getting some table treatment done, like massage, adjusting, stim, is as good or better than exercise. But here's why you actually have to read these things. So let me read the highlights. Exercise therapy may not be more effective than passive conservative treatments. Combined with education, exercise may not be more effective than education alone. Why am I saying that I disagree with that? Main reason was, and let me find the exact time frame here. I'm looking for it. It's in here. Short term. Where do they say there's confirmed short term? I believe this was at 1 month, if I'm reading this correctly. So, shocker, shocker, if we're looking at very short-term benefits, what seems to help patients with just the pain aspect? You're right. Exercise in that short of a window may not beat out learning about the condition, and it may not beat out manual therapy because, one, we have time and biology that we're actually dealing with here versus psychology. And let's take a look. This one's gonna take me about 3 minutes. So if we look at pain and pain education, it is very effective in helping people in pain because if you understand your condition, that not every hurt equals harm. It helps your brain organize the inputs it's getting from the painful region, and it understands consciously, all right, it hurts, but based on what I know about the condition, I am not damaging it. Therefore, I can still keep doing what I'm doing as long as I follow certain guidelines and parameters. And if you give that just a little bit of time, you really tone down how painful the area is perceived because it's not perceived as dangerous. So education alone is shown to improve people's self-efficacy, so the ability to handle their condition on their own, and it can handle and reduce pain on its own. We already know that from lots of other research articles and literature. If we look at manual therapy, almost every bit of manual therapy research that I have seen shows that in the short term, it is fantastic because we get different types of benefits to the patient, ranging from, granted, I'll admit, placebo to short-term mechanistic, physiological, neurophysical, and basically, in a weird way, psychological benefits, because these manual therapies are being done by somebody that is perceived to be a professional in their field, by the person receiving the therapy. These things almost always feel good, which means they temporarily tone down people's perception of pain. We can get some physiological mechanisms to benefit us in regards to the healing process. So yes, short term, it is fantastic, which is why if you look at this study in just this short of a lens, exercise has not been given enough time to beat out the other two interventions. So again, it's all about the expectations and how you phrase the question to get the answer. If time is a factor and a patient needs to get out of pain as fast as they can within 4 weeks, and they only have time for one or two of the interventions, what do you go to? I would still encourage as much as I can exercise. I don't, again, in this hypothetical, this person is so strapped they can't exercise, which isn't realistic, but for argument's sake, fine. They can pick whichever one works best for them. If they prefer to learn about the condition in a deep and meaningful way, you're going to get pain benefit. If they prefer to have a bunch of manual therapy thrown at them in the first 4 weeks, which again, I'm not knocking it. I enjoy it. If I'm hurt and I have the time and money, I am going to do it. However, if we then shift the goalpost where now we're looking at 3, 6, and 9 month timelines, exercise, you will see, beats it out because you will now be going through a bunch of different things as far as exercise goes. There are so many other benefits to exercise that you'll be more capable. The body's reorganizing itself around the movements that you're doing. You're becoming more resilient, more adaptable. You are improving your metabolism, you're improving so much that oftentimes if you ask a patient doing it long enough, hey, how's this pain going? They may answer, oh, it's the same. But if you then dig deeper and say, all right, what are you now able to do? Well, 6 to 9 months ago, I couldn't even lift 10 pounds. Now I'm lifting 40, but you know what? I'm still in the same amount of pain. It's like, hold on, pause. You're telling me you're lifting 4 times the amount of weight in that painful area. Do you see what you're saying? The pain is the same, but you're so much more capable. And oftentimes, if you really ask them about it, that first warm up, maybe 2 warm up sets where they're hitting 10 pounds, 20 pounds, what was painful in the past, it's no longer painful. They have to go farther to experience the same pain. They just get so accustomed to it, you don't pause and think about that. So exercise will beat it out in the long run, which is why if we look at all of these 3 things that it's comparing, it shouldn't really be a comparison of necessarily what's better, and we shouldn't use that as isolating a treatment in the real world. We should be looking at this, which one in certain time contextual factors is the most effective, which means if we're doing this sequentially, where a patient is hesitant and you're still building trust, maybe you do start with the education piece and a little manual therapy until the person trusts you enough to follow through with your exercise recommendations. All of these should be in your treatment when it comes to treating people in pain. So education is a must. Manual therapy is a nice cherry on top. Exercise and all of the other benefits that come along with it, I would argue, is a must, but not every patient is ready for that right off the bat. So you should be including these three aspects in your patient care, either all at the same time or throughout the entire course of care to match the patient in front of you to give them the best chance to succeed with whatever painful condition they're going through. And again, specifically with this one, it's talking about rotator cuff. So, food for thought, my 2 cents, whatever you want to say. Next study, comparing the effectiveness of exercise interventions for patellar tendinopathy, a systematic review. This one, it's basically a matter of you don't necessarily need to focus on eccentrics, concentrics, isometrics, as long as you're challenging the tendon in a way where it's heavy. So yeah, you can load it isometrically. You go for long enough time, it's perceived as heavy by the body. You can do eccentrics because if you do them right, you don't need to do a whole lot of them because you're using a fair bit of weight over a long period of time. The knee thinks it's heavy. Or you can just slap a bunch of weight on something like a leg extension machine, 5 to 10 reps out, make sure it's difficult. What do you know? You're going to get some great benefit too. Yeah, let's see. Conclusion. The revised evidence does not support superiority for any individual exercise intervention that we have observed. So pick which one matches the patient preference, and how they feel the best going through it. Sometimes if you need to, this gives you carte blanche to mix it up if it's just for a fun thing. Because don't get me wrong, I'm kind of weird in some respects that there are certain exercises I could do every week and not get bored with them. There are others where they're going to be on a lazy Susan rotating basis because they're effective. They're great. But boy, does my gas tank run out really fast for doing them. So this one tells us we can do a whole mess of a lot of things for the knee, and we're going to get some benefit as long as we're challenging the knee in the right way. The effects of manual therapy and splint therapy on patients with temporomandibular disorders. What do you know? Both work. You combine both together. Patient's going to get a ton of benefit. Again, as long as they're done in the right way, it's assessed the right way, and it's the right condition you're treating. So frankly, it's one of those things where you see somebody like myself doing the manual therapy side of things, and you find a good dentist or orthodontist who can actually take care of customizing some sort of a splint for your painful jaw. What do you know? Collaboration is king. Multiple providers taking care of a condition that they have overlapping expertise in. Fantastic. Do I know the teeth and the jaw as well as an orthodontist? No, but I know the human system. I know the muscles. I have personal experience with my own TMD, and I'm able to do different interventions that they aren't, which is why when you combine us, when it comes to conditions that overlap, we have great benefit. The same can be said for a whole bunch of things. When it comes to spine stuff, depending on your condition, I can handle a load of spine conditions out there, but by gosh, I do need good neuro, I do need good ortho, I do need good surgeons in my roster so that the patients that need them get the best patient care overall, and vice versa. So collaboration, folks. Run from somebody who says they can do it all and you never need anybody else. They do not have your best interest in mind. All right. Oh yeah, this one was a little interesting. Association between hormone replacement therapy, HRT, and the onset incidence of tendon injuries requiring surgical repair in perimenopausal women. So what do they find here? Well, if we go down to the results, hormone replacement therapy users had significantly higher rates of several tendon abnormalities compared to matched controls, including rotator cuff tears, biceps tendonitis, elbow tendonitis on both sides, and Achilles tendinopathy had similar rates between the two groups. So really the only one that was kind of spared was the Achilles. Surgical repair was more common in the hormone replacement therapy group, including at the biceps region, as well as the rotator cuff. So their conclusion to the study was the systemic use in women aged older than 45 was associated with increased risk of tendon injuries and a greater likelihood of surgical repair, although the absolute, here's a key thing, although the absolute risk differences were modest. Okay. So we talked about, they say significantly higher, but if you look at what is 5% versus 8%, okay, it is significant in terms of the statistics and ratios. So it's not nothing. But I also don't want us to think about, you know, absolutely shunning hormone replacement therapy, because these things need to be weighed on a scale of ROI, return on investment, or even probably a better one would be risk analysis. Is the benefit that I'm getting from the therapy, does that outweigh the risks of getting the therapy or treatment? Your provider should weigh this out for every intervention. I do it for anything that I do to a patient. Do the benefits outweigh the risks for adjusting certain regions for certain conditions? Does it outweigh, manual therapy? You always do it. So if you're doing HRT more for trendy reasons and you don't have a solid need that couldn't be handled in some other way, might be a fair talk with your provider to maybe consider going off of HRT. But if you have a legitimate reason for needing the HRT, just understand these may be more likely in your future, not that much more likely, but they may pop up a little bit more often in your future because of this associated risk, which means it's not doom and gloom, and you can anticipate, hey, if this has a little bit higher risk, I'm still accepting that risk. If I do happen to develop it, I know that this is playing a factor, which means my care will be managed by my primary, figuring out my HRT dosage, approach, etc., vector. And I'm now going to seek a professional to take care of this problem that I knew was a possibility given what I'm going through. So I'm not advocating against HRT. I am not saying don't take it, because again, all of treatments are for the right person at the right time for the right reason. HRT is one of those. Just understand that there are associated risks that are popping out because it's becoming more of a prevalent therapy. That's all I'm saying. Next study. Is there an association between diabetes, neck pain, and back pain? Yes. That's really all this study showed. Is it a surprise to people that have any of the conditions or know people that have diabetes? No. Given what stereotypically your typical patient avatar with diabetes, it's not surprising that they have some sort of pain because of the, I'll call it the metabolic environment that the person actually has that has diabetes. And I'm referencing both. Type 1, there's not much you can do outside of, no, let me rephrase. There's plenty that you can do, but you do require exogenous insulin because of what type 1 is. Type 2, arguably, you have a lot more ability to go off of some of the medications as long as it's done right between your primary and the person who's going through your lifestyle factors. Is it a guarantee? Not always, but very oftentimes it is, because it's in your hands to get yourself out of the problem that many people got themselves into. There are exceptions to this rule, and I know a bunch of people out there, keyboard warriors. Well, what about this story? What about that? There are always exceptions. However, we also see the trends in the data between type 2, lifestyle, obesity, diet, exercise trends, etc., which stands to reason if we reverse those, we should see a reduction in type 2 diabetes rates because of how type 2 diabetes develops. Anyway, off track. So it's no surprise that people going through, or the people that have diabetes, and specifically type 2, are going to have significantly higher odds of developing things like spinal and neck pain. And I believe this one was here. Diabetics had 1.3 times higher chances of developing spine pain and 1.4 higher odds of developing neck pain. So it's like a 30% and 40% chance, or higher chance, I believe, if I read that right, than somebody who doesn't. Not good odds, not good numbers. And if you currently have that, maybe it's another additional reason to get out of it. And it's also why anybody that has these conditions, I will typically say there may be not a limited benefit, but there's only so much that I can guarantee or promise working with you because of what Oh, because you're a diabetic. So like I will extend treatment times as far as like total treatment length. Hey, I have to acknowledge the body doesn't always respond the same way between a diabetic and a non-diabetic, which means it might take a couple more visits. It might take a couple more weeks or a couple more months to see a similar benefit. If we're able to take care of the diabetes, then we can start putting you in the normal responder category. And I'm using air quotes for that for a reason. Diabetes affects a lot. I mean, if you talk with med, a lot of the MDs understand that wound recovery is affected. Talk to neuro, I mean, diabetic neuropathy is a thing. So your body is going through something entirely different because you have diabetes. So no surprise that people are going to have higher odds of pain. And if you have diabetes and you come to me with spine pain, as long as it's just non-specific, I'm still going to take that diabetes into account when I'm making my recommendations for those reasons. Now, before I go into soapbox again, next up, incidence and preoperative risk factors for failed back surgery syndrome. So basically, postoperative back pain is what this really is. Failed back surgery, I believe in the literature is something like 25-ish% of all back surgeries have failed back surgery. Oh, wait, it says right here. Overall, the failed back surgery incidence rate was almost 27% based on the disease code and reoperation definitions that they found in insurance databases. Things that stood out that put you at higher risk to develop it were advancing age, peripheral polyneuropathy. So if you had neuropathy somewhere in the extremities, obesity, diabetes, what do you know? Hypertension and current smoking status were independently associated with increased risks of failed back surgery syndrome. If you also had decompression surgery and spinal canal stenosis, it also showed up as elevated risk. So if people had either a higher income to pay for preventative or preoperative factors, if they had employment-based insurance to reduce the financial burden, and if they maintained moderate physical activity, these things were found to be independently protective against failed back surgery. Food for thought. But again, I'm not going to soapbox for half an hour on that. Next. Impaired knee joint position sense and chronic patellar tendinopathy is associated with fear-based movement, but not increasing pain response in the brain. I think the only thing I need to do is clarify that. I don't need to say much more. If you can't sense where your knee's at in space, a lot of the times you will be more hesitant to move through those motions, and that will make you avoid those movements, which will actually make the knee on average more painful because the brain will often fill in the sensation of pain as a protective mechanism for something it doesn't feel like you can control. So if you have a reduced position sense for whatever reason, you're coming out of an injury, you're coming out of some painful condition, you have a new flare-up of a tendinopathy, etc., you don't necessarily perceive the knee in open space as well as you normally do, whether that's with walking, running, squatting, etc., which means your body's going to be, and your brain is going to be more fearful of certain movements. Your overall pain perception, so how much stimulus it takes to become painful, does not increase. So your brain chemistry doesn't necessarily change because of this. So even though it's a chronic tendinopathy, it doesn't seem to lead to central brain changes to deal with the issue. However, it's still something that we need to treat, and it means that we can also take a proprioceptive rehab perspective. So it's not just rep things out that we must do. Sometimes we can just do different rehab strategies to give you a reconnection, a sensitivity of being able to feel where that knee is at the space. We can gain a lot of benefit, and then we can also go into repping it out, strengthening it out, running it out, whatever we need to do. So again, like I talked about a few studies back, this just gives us an angle to work with the knee in a way that is tolerable to you before we get into the stuff that may be required, but you may not be ready yet for. Hopefully that makes sense. Anything else that I wanted to say? No. All right, let's just keep going. Let's keep banging these out. Uh, Potential reason for idiopathic scoliosis in kids, they're looking at as kids grow, certain inflammatory markers and gut health may be influencing the development and severity of scoliosis. This is prospective, so nothing to really say it's a for sure thing, but a very cool angle to consider when it comes to why do we have idiopathic scoliosis? Maybe how do we manage it, screen for it, treat it before it becomes a significant issue. So something that is cool, something that we can keep our eyes open for. Next, standing work and low back pain. What are risk factors? There's a lot, but the big one that stood out to me and what I wanted to bring to you was regardless of position, labor type, etc., almost everybody, once you hit the 1 hour mark of sustained standing, that's when low back pain develops. So regardless of factors, if you know you're going to have to stand for an hour, odds are good that you're going to have back pain. Gives us different types of interventions as a clinician, as an employer, etc., to mitigate that by giving patients options so that you can really say, all right, if they are going for 45 minutes standing, they absolutely must. This is where you can sneak in a 5-minute break of some sort of different movement that isn't sustained standing in a single area. A walk, sitting down, mobility drill, standard operating procedure for the factory as far as like a stretch protocol. There's lots of ways that we can do it, and there's lots of different ways that could be beneficial to the company. And just showing this, hey, it seems to be at a 1 hour mark, gives us a very actionable intervention to reduce worksite low back pain, which is a huge burden. All right, next, ultrasound assessment of the cervical and craniofacial muscle thickness in individuals with and without cervicogenic headache. The big one was these thick muscles right here, these SCMs, as well as traps on the right side. I don't know why it was just the right. Maybe people had more incidents there. But changes in this thickness were predictive of somebody having cervicogenic headaches, I believe. So the SCM and upper trapezius thinning seem to be associated with cervicogenic headache. Gives us another potential reason to strengthen the neck and work the neck, because this is a hugely underworked area in somebody's training. Like I see almost nobody training their neck directly. When it comes to seeing people at gym, I, if I was younger, I could understand why. Like I didn't know when I was younger, but hey, I'm sounding the horn, train your neck. Let's get this thing more robust and more capable. So, all right, next up, association between the long head of the biceps tendon and rotator cuff tears. A cool prospective thing because there's anatomical variety, like not everybody's the exact same. That also goes for, where your muscles are anchored. There is actually some variation on muscle direction, muscle length, and where the two anchors are for the muscle itself on the bone. And it seems to be that for some people, where that long head is anchored influences risk of requiring rotator cuff repair surgery because you had a rotator cuff tear. So something that is neat, which means it may be more, it may help in triggering the yes or no answer for a surgeon on who gets a rotator cuff repair, because they can look at this study, go, all right, does the person that's coming into me with shoulder pain that I'm sending for an MRI, that MRI shows X position of the long head. Oh, that long head position seems to be just fine. Odds are good that they can completely recover non-operatively, and we're good to go. Versus patient B, all the same symptoms, long head's in a different spot. That one doesn't seem to repair as well on its own. Conservatively, we should go in and cough it up. So a cool thing that helps us sift through who's going to get the absolute best bang for their buck going into surgery versus who's going to get the best bang of their buck for conservative care. And this is something that we can collab with between ortho, radiologist, and practitioners like myself. Sounding the horn again on opioids. A recent study from Australia showed that in Australia, 1 in 6 patients admitted with low back pain received high daily opioid doses. I'm not going to say too much about that other than it's still very prevalent. You're still going to hear people like myself talk about it because it is still a highly utilized intervention. And again, it needs to be the right tool for the right reason. The problem is it's sometimes the only tool available and it's used for the wrong reason because the system is set up where there's not many other medications that can directly affect, even if it does, it doesn't always affect it, but even if it's one that is easy to give, easy to write a script for, and easy to justify, that doesn't mean it's the right thing for the patient in front of you because of all of the risks associated with opioids, like opioid addiction, the side effects, potential for death from abuse, etc. So while they are very, very powerful, potent, and absolutely do have a place in healthcare, just because somebody walks in with low back pain and a well-meaning provider doesn't have anything else available to them, they're going to write them a script for an opioid. We go back to that ROI, or risk versus reward. I don't think it's worthwhile for most of those conditions. I think we need to have a better referral network between providers like myself who can handle these things in a non-operative way and really show extreme efficacy, safety, and benefit to the patient with these conditions that do not require opioids. So we absolutely need collaboration to reduce these numbers overall. So let's refer more back and forth between primaries, between PTs, between DCs, between occupational therapists. We need even better referral relationships and connections to make these numbers less. Next, does adding cervical mobilization to shoulder mobilization improve pain, sensation, and function in subacromial impingement syndrome? Short answer, yes. We go back to the last study that I talked about doing mid-back work for shoulder pain. Very same, it's almost the same exact idea, just a different local area. So you add in the neck, shocker, you're going to get some downstream when it comes to dealing with shoulder pain. So, was there anything specific about it? No, when all of it was combined, including cervical mobilization to conventional treatment for the shoulder, it showed the most significant and most effective results in reducing pain, enhancing pain-free range of motion, and improving sensory function. So again, you could do them in isolation, but why? Combine them all. Next, risk factors for shoulder stiffness after rotator cuff repair. Let me scroll down and read them again here. Things such as older age, diabetes, fatty infiltration to the region, and subacromial decompression were identified as risk factors for postoperative stiffness. So if you're going to go in for shoulder surgery, make sure that you can't really do anything about age. So if this is one of those things where you're 40 and somebody says, all right, you're going to need a shoulder surgery by the time you're 70, let's take a few years, maybe get you to your mid 50s and where you're still younger, then we'll pull the trigger on surgery because you're still younger. You had time to work on it. You had time to pre-op help it. You're at a better chance of having a better outcome. If you have diabetes, again, loads you can do to reduce the severity of your diabetes if it's type 2, even if it's not outright. I'm not going to use the word cure it, but manage it to the point where you go from type 2 diabetes back to pre-diabetes back to normal. If it's type 1, again, you can still be very physically fit and you can be in a state of physical health that is fantastic going into the surgery and mitigating your risk, even if you have type 1. That goes the same for fatty infiltration. Fat infiltrates oftentimes when you don't move. So if you just let it sit there, let it kind of stay soft, fat's going to build in because body's like, I got this free space that's not being used, and I've got a whole bunch of triglycerides and all these different things that I'm eating and bringing into the body that I need to shunt somewhere. So you know what? It's like a flat surface syndrome. There's open space. I'm going to shove stuff there, even if it's supposed to be healthy muscle. Yeah, he ain't using it. So if you're going to need surgery and you want to have less stiff shoulders coming out of surgery, take care of your body, move. Effects of whole body strength training on pain and strength in chronic low back pain. Do it. This study just shows, hey, whole body exercise seems to help with chronic low back pain. Who would have guessed? Next study. The effectiveness of cervical spine and diaphragm manual therapy combined with breathing, re-education exercises on musculoskeletal, respiratory, and psychophysiological outcomes in patients with nonspecific chronic neck pain. What was that? What does it mean? It means that they're really looking at does breath training, does diaphragm work, and cervical spine work improve neck pain? Yes, but not always. Testing. All right, I'm back. Microphone disconnected for a sec. So let's get back to the study. Um, Here's the thing. Yes, they all worked. They don't have to work through direct means like, oh, I'm manually releasing the diaphragm, therefore they're going to breathe. No, you're just bringing awareness and attention to the area. And sometimes for the right person, that's all that's needed to show benefit. So, yes, this study showed that specifically those things had benefit for the patient, but these are by no means the only things that benefit the patient, which means as long as you have the right education, are talking about it for the right reasons, about the right way. Like, if you just go about doing the right principles for the treatment, the patient's going to benefit. So if you have a person, and I have a few patients where you have this kind of rib pain and just this tight feeling, I'm going to go there because the patient feels symptoms there, and I'm going to try and get them to relax and calm down by just doing some work there. Am I making the diaphragm more mobile? Not really. I'm just bringing awareness to the area because the patient's complaining about it. I'm also going to, because it's neck pain, do something with the neck. Shocker. I'm also going to add in different types of exercises and education pieces. So I've had patients I've had do breath training because it's calming, not because I need to absolutely change how they breathe. It's like, no, I'm giving the patient a dedicated 5 minutes where they're just chilling out while I'm giving them education. So on paper, am I doing it all? Yes, but not really for the reasons I think the study was trying to highlight. You tell somebody to breathe, you can get them into a relaxed state. You work an area that seems to be tight by a patient, they like it, and they're more prone to doing the other interventions that you're going to recommend, like exercise, mobility work, nutrition, etc. So it's effective for a lot of different reasons that aren't necessarily highlighted by the study. All right, next up, British Journal of Pain. Disease burden of low back pain in middle-aged and older women are attributable to three factors. Let me scroll down to read them out for you. Let's see. Occupational ergonomic factors emerged as the most pressing risk factor. So again, go back to standing still for an hour, things like that. While high BMI is potentially the fastest growing contributor. So those were two. The third one, I believe, it says population growth and aging were likely acting as the third additional primary driver. So more people coming into the area who are getting older, who have poor ergonomics and poor weight management are the ones that are really showing to improve or not improve, increase the disease burden for back pain. Huh. Almost like we're onto a theme. But let's talk about something else here. So, yeah, still in the low back. Lumbar microdiscectomy and postoperative activity restrictions. This study actually showed that if you liberalize, so if you ease up on the restrictions postoperatively and let patients kind of take it as self-guided, where if they feel good at, you know, 10 days, let them do things. They seem to have better outcomes than the patients that you tell to have to be bedridden for 2 weeks, then no heavy lifting at all, more than 10 pounds, and for another 6 weeks. It's like, why? Like, I think outside of, you know, ripping a stitch where it's like, all right, let's avoid really fast like rotation stuffs because you'll rip a stitch that way. Patients are usually pretty good about figuring things out, and that's what this article showed, that liberalizing postoperative restrictions improved immediate short-term patient outcomes out of the surgery. In fact, it also says uh, liberalizing did not compromise outcomes or harm the patient. Cool. Food for thought. We're almost done, I promise. Changes in pain-related fear predict shoulder disability and rotator cuff tendinopathy. So basically, during a course of care for shoulder tendinopathy, if somebody didn't have that great of improvement in the short term to the point where they were now getting fearful of all movements, who knew? They got worse scores. But if you're able to get somebody to move well and or understand their condition so that they don't become fearful of movement, they did well, especially in the long term, recovering from rotator cuff tendinopathy when it comes to exercise. Next up, adhesive capsulitis. The effects of adding median nerve mobilization to the glenohumeral joint mobilization in patients with adhesive capsulitis. This did not improve range of motion, but it did improve pain perception and subjective functional outcomes that weren't associated with range of motion. Reason being is you're giving somebody a tolerable, meaningful movement to do with a very painful condition. It seems to calm the whole area down. Does that mean that the nerve is stuck? Therefore, nerve mobilizations will help it? No. These nerve mobilizations are very oftentimes very low load, very effective means because they're not going to put you in positions that are stressing the joint a whole lot. So if you tell a patient, hey, I think these nerve mobilizations will help you, I mean, they're simple, like you can just move, like if I'm out of frame here, I can just move the wrist. I can do a little bit more of a flow where I can move the head while I'm moving the rest of the arm. Like you can customize it a bit and tell the patient, yeah, we're getting all the tissues to move without putting stretch on a nerve. Like you can do that education piece if you want, but having a person with a very tight shoulder that doesn't want to do this at all, like, all right, here, keep the arm down here and then do this. It's like, oh, I'm getting movement to the area because I'm dedicated time to doing this that my provider said. Now my shoulder hurts less. Shocker. So getting this to move passively, telling a patient to do a tolerable amount of movement reduces pain, improves their subjective experience going through this fairly long resolving condition. Cool. Non-operative management of postpartum diastasis recti. Getting patients to exercise reduces the anatomical distance of the diastasis recti, especially the sooner you're capable of doing it, the better. This did not improve all the functional scores. So they did 9 randomized controlled trials that actually analyzed diastasis recti distance. And what they found was interventions initiated at less than 3 months postpartum achieved greater reductions in diastasis recti than delayed starts. Crucially, no significant difference was found between specific types of training, so long as a consistent, structured exercise program was utilized over no intervention or standard of care. Regarding the functional outcomes, those did not seem to change a whole lot. So again, there might be a time piece where you just had a kid. There might be some time that your body needs to reorient around functional capacities, functional outcomes. However, getting somebody moving and utilizing their body more seems to reduce the diastasis. So if we have, what's going to be the best way for me doing this here? So if my thumbs right here are the connection point between the left and the right ab muscles, diastasis, because of the way the baby sits, all women going through pregnancy are going to have some, form of diastasis. It really comes down to how many inches, or sometimes it's measured by fingers, like how many fingers can fit in between the two ab muscles. Sometimes it's pretty severe. Sometimes it's not so much. So doing exercise, so if somebody has like a diastasis here where they're pretty separated and you can see it where maybe they have some contents herniating through the open space, exercise can reduce that distance, even if functionally they don't feel like they're that much more capable than somebody who doesn't go through exercise in the short term. So Just like the microdiscectomy, maybe this is a reason to get somebody to start moving sooner than just a hard, rigid cutoff of a time-based criteria. Now, just like with the idiopathic scoliosis paper, this one is prospective, and this one's looking at maybe mitochondria serve as a source of the body having and developing osteoarthritis. Say what? Well, the mitochondria do a whole slew of things. And so this maybe says that depending on the health of the mitochondria, it could trigger a cascade effect of the body thinking it needs more or less minerals at a given area, ergo osteoarthritis. So it's cool. It's something to keep an eye on, and it's food for thought. Last 3 studies. This is a lot. Cardiovascular health and osteoarthritis risk. Simply put, poor cardiovascular health, worse osteoarthritis risk, and vice versa. Better cardiovascular health, reduced osteoarthritis risk. Enough said about this one. I love this study. Yet another reason to get out, get moving, and actually doing cardio. Now, don't get me wrong. I don't like it just as much as anybody else, but find one that is fun, find one that is meaningful, and still do it. Effectiveness of radial extracorporeal shockwave therapy versus other electrophysical modalities on pain reduction and functionality with patients with plantar fasciitis. It didn't perform any better than any others. So this one in particular, because you definitely feel a good shockwave. If you absolutely need to feel the pain to think there's a gain, by all means, go get a shockwave. If you're somebody who doesn't have access to a shockwave, don't think, oh no, I've heard shockwave is the best thing for plantar fasciitis. I am doomed. I'm not going to get. That's not true. It doesn't perform any better. You can get it. You don't need it. Really, again, patient selection. What is the best for the patient at any given point in time for any intervention? So if you only have other electrophysical modalities, or if you only have rehab, nutrition, and lifestyle, you're still going to be just fine. It's just a matter of, again, matching therapies to personalities, to people, to clinics. That's all this is really saying. So if you have somebody that says, hey, you need shockwave, you need my shockwave machine because that's going to cure it, wave them off. No, they're selling you something. Hey, I have a shockwave machine. You want to use it for your plantar fasciitis? No. All right. You want to do these other things? Yep. That's a fine provider. They're not forcing you into something that has no greater benefit than any other. And again, you can then select what patient is going to best fit the intervention. Last one. Common risk factors for knee injuries in runners really came down to 2 things. One is prior injury, like every other thing that we have out there in the literature. And 2, it came down to load management, because it is so easy to double, triple, or quadruple your actual total physical impact on the body running. Patients have, let me rephrase. Running seems to be something that patients easily overload more than any other exercise. Therefore, that's why they're more subject to developing pain via running. So running is dangerous for the knees. It's like, no. Like hey, person, did you just squat 200 pounds? Yeah, great. Slap on 450. What? Your knee's going to hurt if you're able to do it? Yes, because you went from 2 to 450 pounds. But people with running, they sometimes like, you know what, 1 mile felt good. Let me go to 2. You just doubled the amount of effort, the amount of exercise you just did. I'm going to run at a faster pace. I'm going to increase my speed. I'm going to increase my distance. I'm going to, like, there's so many variables that so many people ramp up too quickly, which is why they develop knee pain. But flip token, it's also so easy to then mitigate and manage runners in this sense. If you're a runner, it's easy to somewhat manage yourself and triage yourself, because you can then play with, all right, my knees ache. When do my knees ache? Is it at a certain mileage? Is it a certain pace, etc.? You can then build up to it or build up around it. And then if it still stays, then you can seek somebody like myself out for actual care. So biggest things that stand out: load management, prior injury. Thank you for sticking with me this far. Holy smokes, that was a lot. Let's get back into doing just a handful of consistent studies and not having these long-winded, I shouldn't even say they were long-winded, just not a lot thrown at you. Till next time, stick with us. Thank you.